was expected of him. I'm not going to thank him for making me a heart surgeon because that's the job he accepted for himself.
Correct.
But what I want to thank Peter for his humility and for the person he was that made it so difficult for us to follow in his footsteps. Although he denies the giant that he is, but in our minds and in our hearts, he is an unequaled giant. Peter, we love you.
So do anybody on the Zoom, Dr. Feliciano, Dr. Rizicki? I saw Iggy. Iggy, it's Michael Halkos. I haven't talked to you in a long time. Any comments from anybody?
Yeah, this is David. Peter and I worked together for almost 20 years. He was one of the most loyal and true friends that I've ever had in an academic center. He was always there when we needed him as backup for trauma. And I think he remembers on many operating days after I was done with a case, I'd go over to OR 12 and harass Peter just to remind him that I was there. And I gained great respect for his technical skills. I watched him operate repeatedly, but mostly I appreciated his friendship. When we come back to Atlanta, which has been frequently, Peter and I have a meal together because I do miss him. I miss HIFO. And Grace and I had a small part in training all three sons, and we're quite proud of that. But mostly I want to thank Peter for his excellence as a role model. And again, for his incredible loyalty during our 2 decades at Grady. Thank you, Peter. We really miss you.
Thank you.
Thank you, David. Thank you. I miss you too.
I would just like to add, I think that
Thank you too.
you've made extraordinary contributions, and 2 things I remember when I was at Grady. One was you're coming in for a cup of coffee in the kitchen in the morning in the Glenn building, and we would always chat and say a few things about maybe what cases you were going to do, and it was just a nice memory. And then also whenever I was on trauma call, if there was a gunshot wound or stab to the heart, and our fellows were there, we always felt better if you poked your head in and said, yeah, that looks great. So thank you for all your contributions. It's extraordinary life.
Thank you, Grace. You brightened my day during the last several years after my retirement, coming to Grady and going to your office there. It was wonderful. I miss you.
Thank you.
Any of the others on the Zoom? I saw Iggy on there earlier, but did he sign off? Did he sign off? Okay. All right. Do you want to do?
Yeah, that's when you go ahead and
Okay.
do this first. So Michael's going to present a gift for you, Dr. Symbas, on behalf of everyone.
So for those of you that don't know, the Halkos family and the Symbas family has been very close for, before any of the kids were ever born. So my father and Dr. Symbas were very, very close, very involved in the church. Dr. Symbas and his wife baptized my youngest brother. So they're godparents to Stephen. And so we've been part of their lives. They've been part of our lives for, gosh, I guess a long time, 50 plus years. So anyways, this goes beyond surgical training. And of course, I was fortunate enough to also learn from you as so many others did. And so this is just a small token from the department. This is a summary of all of the articles that you've ever published. I will comment that I think 4 of the last 5 of the 168 articles have my name on there too. So, your contributions are enormous to the specialty, to Emory. personally to me, obviously, and congratulations on a life well lived.
One of those copies will stay in the chair's collection at Emory, so that we can make sure that we're keeping your legacy alive in the Department of Surgery. One will remain in our resident library so that future generations of Emory residents are able to read about your incredible work. I remember quite frequently being told that any of us should try to be a fraction of the surgeon researcher that you were, while being the kind of clinical, incredible clinical role model that you were to so many. And so we want that legacy to stay strong with the future generation of residents. And we have gifts for your three sons of the copies of the book as well, because he obviously needed his family with him to support him through all of this. So.
Thank you very much. Thank you.
And for anyone who would like a copy, you can be sold a copy by us at a small markup to help support the residency Galloway McKinnon Alumni Society.
I didn't understand.
They're selling a book.
We're selling it too. Yes.
Feel free. All the proceeds goes to whoever you want.
Thank you.
Can I say a few words?
Yes.
Absolutely.
I'm Jacob Dartian. I had the good fortune of being trained at Emory. Dr. Symbas was one of my mentors at Emory. I finished my training in 1992. So when I was a resident, it was a joy every time operating with Dr. Symbas. And he taught me many things in the operating room and outside of the operating room. The fund of knowledge of this man is boundless. And so every time we would do rounds, I would be completely lost how much this man knows and how much he cares about the residents. He cared about every one of us. And that wisdom was imparted on us every day, on rounds, in his office, in the operating room. Many times he would, I'll tell you a story. I was doing a case at the VA with him, and I just finished rotation with Dr. Craver. And Dr. Craver, being Dr. Craver, when he would see a big, juicy first septal who had osteal lesion, he would dig out that septal and bypass it. So here I have a case. There is beautiful septal artery. And so I went on bypass. Dr. Symbas came in and I'm dissecting down. He said, "What are you doing?" I said, "Well, I'm going after that septal." He said, wait. Have you ever seen anybody die of non-grafted septal? You know, it was a cooling thing to us to see, to learn from this man who had so much wisdom, that he made us safe surgeons. And that is invaluable. I still do my aortic valve replacements the way he and Dr. Guyton took. And when I show that technique to my residents or to my fellow surgeons, but we have never seen this before. Was it published? No, it's not published. But it's the way Peter Symbas first taught me how to replace the aortic valves. When I was his resident, I got hold of the book, The Trauma of Thoracic Trauma. Dr. Symbas signed it. In my multiple moves from place to place, I lost the book. Then we come back to Emory, and I'm faculty now. And so I found the book on Amazon and brought it to him, and he signed the book again. So I have that book, Dr. Symbas. Thank you very much from the bottom of my heart, from all the residents that you trained, that, you know, what you gave us to us is invaluable. Thank you.
Thank you too. You were inspiration to me too. The effects perhaps were mutual.
Thank you.
And certainly from my point of view.
Thank you very much.
Dad, it's humbling to be your son. I am eternally grateful for everything that you did for us. I always will.
Dad, we all are. Mom would have loved to have been here, I can assure you.
I
She's
wish
with
you-
us, I know, but she would have loved to have been here.
I wish she was really, but we don't have control of this thing.
Dad, the gift that you've given us and you've given to your grandchildren, whenever a difficult moment comes up, we can always look back and say, what would you do?
Mhm.
And the answer will be. Dad. Yeah, thanks everybody for doing this too, y'all.
Yeah.
I mean, we respect all of y'all. Y'all are handling our training, most of you, but thank y'all very, very much for this.
Marty, thanks for hosting wherever you are.
Control your animals.
Yeah.
Oh, wonderful.
Thanks for being on Zoom. Yeah, we miss y'all.
Okay.
You need to call me when you come back in town too.
All right. Dr. Dente, how does that look?
We can see it.
Okay.
I would love to see that other slide deck someday because we couldn't see it very well.
We'll get it to you. All right. Good afternoon or good evening. My name is Brendan Lovasik. I'm one of the chief residents at Emory. Today I'll be discussing a topic that's near and dear to my heart, xenotransplantation. Because Dr. Symbas is our honored guest, I wanted to focus more on the cardiac xenotransplantation side, which has a lot of history and a lot of very interesting characters who've performed pioneering operations from a xenotransplant perspective. For those who've been to these meetings before, this is our 9th meeting. So we've had a number of wonderful Emory legacies that have been a part of this. And I'm very glad to have back in-person meetings. Every meeting, I add one person to the roster of classic chief resident photos. So we're going through Dr. Dodson, Dr. Wood, Dr. McKinnon, Dr. Galloway, Dr. Srinivasan, Sharma, and Ingram. We now add one more to the list. There's Dr. Marti Russell in 2010 with somebody right behind her who looks familiar. So I wanted to start by discussing xenotransplantation in general, because as with anything, the core concepts of xenotransplantation extend well beyond cardiac xenotransplantation. So who knows when the first clinical xenotransplant was done?
I guess 63.
Anyone else? All right. Who is the
in a human?
Yes,
Isn't this the baboon part, the little baby?
we'll see. All right. Who are the most pioneering, ingenious people that you know?
Egypt, in Egypt.
Hardly.
The Greeks. So the first clinical xenotransplantation was Daedalus of Crete, who was the father of Icarus.
Brendan, your slides aren't advanced, so are you gonna present them?
I think so, but
Sorry,
Huh.
Dente just texted me.
is that working now, Dr. Dente?
No, we can just see the first slide.
The first one, yeah.
Hold on. Technical difficulty. How's that look? I'm just going to go off of this view. Can you see this view?
Yes.
Okay. So the first clinical transplantation was Daedalus of Crete. For those who don't know, this is actually Icarus's father. And for those who are fans of mythology, he was actually the one who designed the labyrinth that the Minotaur was imprisoned in. So he grafted bird feathers onto his arms and flew from Crete to mainland Greece. His son, perhaps not so lucky, the first acute xenograft rejection was Icarus, and this was caused by a thermolabel adhesive when he flew too close to the sun. So something that we've seen very frequently, acute xenograft transplantation. The first clinical xenotransplantation was actually performed in 1906. Dr. Jabelet of France attempted a renal xenotransplantation twice, both in the same year. The first was with a sheep. The second one was with a goat. He inserted it into the antecubital fossa, so this was clearly never meant to be a permanent solution. Neither graft functioned, and both failed due to vascular thromboses. Dr. Jabelet is, of course, famous for other reasons. He trained Dr. Lariche and Dr. Carrel, and he also invented the Jabelet pyloroplasty, Jabelet's amputation, which is essentially what we would consider a hindquarter amputation, and Jabelet's button, which was one of the first mechanical means of doing an intestinal anastomosis. In 1910, Dr. Unger in Germany performed a renal xenotransplantation from a non-human primate. In this case, it was a chimpanzee into a human. The patient died 32 hours after transplantation, and the autopsy showed venous thromboses in the graft. The first attempt in the United States was done by Dr. Harold Neuhoff, who was the chairman at Columbia. He attempted a lamb to human renal xenotransplant. The patient, however, died 9 days after xenotransplant. For those who are keeping score, this is about a 900% increase in survival, which is how I would report this if I was publishing that paper. He just wrote in his case report that this case proves that the heterografted kidney in a human not being necessary to become gangrenous, and the procedure is therefore not necessarily a dangerous one, as it had been supposed. It also demonstrates that thrombus or hemorrhage at the anastomosis is not inevitable. I believe that this case report should turn attention anew into xenotransplantation. And Dr. Neuhoff, in addition to being the chair of Columbia, was also a founding member of the American Board of Surgery and the American Board of Thoracic Surgery. In the 1920s, Dr. Vonarov, who was a Russian surgeon who moved into France, started a small clinical practice where he would do rejuvenation therapy. He would take baboon testicle cells, grind them up, and then he would implant them into aged men. And the thought was that the vigor of the baboon would be transplanted into the human themselves. I'm not sure how well that went, but I'm sure there was some placebo effect associated with that as well. In 1964, Dr. Dodson, you were off by 1 year. Dr. Reemsma performed one of the closest modern clinical xenotransplants. He reported 13 chimpanzee to human xenotransplants done at Tulane University in New Orleans. He selected the chimp because he thought that the chimp was most similar to humans from an evolutionary standpoint. Though most clinical transplants failed between 4 to 6 weeks, one transplant, it was in a young woman who was actually a school teacher, that survived for 9 months, and she actually was able to go back to teaching before her graft failed. In 1964, Tom Starzl, a man who needs no introduction, reported 6 baboon to human renal xenografts, but again, none of these were successful past a certain point. This brings us to cardiac xenotransplant. There's a number of cases that have been described in the literature. I'm going to focus on a few that I think are particularly interesting and particularly pioneering. First one is the case of Dr. Hardy. Second is the case of Dr. Bailey. And the last is the case of Dr. Griffith, which was most recently published earlier this year. So James Hardy, a very famous thoracic surgeon, was born in 1918 in Alabama, finished his undergraduate education at the University of Alabama, and then did his medical school at University of Pennsylvania, where he finished in 1942. He served for a few years in the Army Medical Corps, and then actually was recruited down to become the first chairman of surgery at the University of Mississippi in 1955. For those keeping score, he is the chairman 10 years after graduating from med school, so no pressure for any of the residents in the room. He was also the first professor of surgery at the University of Mississippi. He had a long and illustrious career. He was the president of the American College of Surgeons, the American Surgical, and the Southern Surgical, all within his tenure. He's famous not only for performing the first human heart transplant, but also for performing the first human lung transplant. We'll focus more on the human heart transplant, but the human lung transplant has an equally interesting story that I would hope to get into at one of our future events. The first heart transplant was done in 1964. It was performed on a gentleman named Boyd Rush, and that's his picture in the bottom right corner. He was described as a 68-year-old man who worked as a machinist in a factory. People have described him as a deaf mute who had a history of hypertension and atherosclerotic disease. He was found down, presumably due to a heart attack, on January the 19th of that year. His lower leg was noted to be mottled with dry gangrene. His face was mottled with clots, and it was again presumed that he had a myocardial infarction that led to his period of being found down. 2 days later, he was transferred to the hospital at the University of Mississippi, and Dr. Hardy assumed his care. He amputated his left leg, which was gangrenous, and his heart was progressively failing. On the 23rd, Dr. Hardy had lined up a brain dead trauma victim who was going to be a presumptive donor for the first human-to-human heart transplant. However, there was no such thing as brain dead donation at the time, and because the human patient's heart was still beating, he was not considered to be a suitable donor. Around 11 p.m. that evening, Mr. Boyd's cardiac shock began getting progressively worse, and he was actually placed on cardiopulmonary bypass as a rescue salvage therapy with the hopes that they could find some solution for him while he's on the bypass machine. Dr. Hardy had actually gone down to visit Dr. Reemsma in New Orleans, which is only about a 4-hour drive away. And he had seen his results with the chimpanzees. And he had actually talked about doing a clinical chimpanzee cardiac transplant unit at the University of Mississippi. Because this was a salvage operation with no alternative therapies, he decided to proceed in this case with one of the chimpanzee hearts as a first-in-human attempt. He implanted the heart. It sounds like everything went particularly well, according to Dr. Hardy's operative note. And these are actual photos from the operation. So you can see the heart of the chimpanzee in the patient. The heart was restarted. It beat for about 60 to 90 minutes, but the patient was never able to come off of cardiopulmonary bypass. The patient died on the operating room table. Here's a picture of the original consent from Dr. Hardy's operation. I think this is particularly interesting. First of all, it's not signed by the patient because the patient was obtunded and intubated at the time. And second of all, it says that while this will be the first attempt at a human heart transplant, it doesn't actually say where the organ is coming from. So if you read there, it doesn't actually say whether or not this is coming from a human, a chimpanzee, or any of the above. But this is signed by the patient's sister, and it says that, quote, "I further understand that hundreds of heart transplants have been performed in laboratories, but that any heart transplant would represent the initial transplant in man." But again, does not mention anything about where this organ is coming from. The next day, the press was alerted that this was the first attempt at a heart transplant in man. The director of public had a statement that included the vague statement, quote, "The dimensions of the only available heart," but did not disclose whether or not the kidney donor or the heart donor had come from. The Associated Press at the time had circulated a story that began with, quote, "Surgeons took the heart from a dead man, revived it, and transplanted the chest of a man dying of heart failure today." At that point, the hospital had to correct them to say, "No, this wasn't actually a human heart. This was actually done by from a chimpanzee." Dr. Hardy published this in JAMA in 1964, and actually he got a fair amount of backlash within the professional societies, saying that this was not necessarily an ethical operation to have been doing in the confines of what he had. A few other names that people may recognize who also performed cardiac xenotransplants. Donald Ross, known for the Ross procedure. He is known for performing the first human cardiac allotransplant in the UK in 1968. And he also described the pulmonary valve Ross procedure, where you take the pulmonary valve and use it to replace a diseased aortic valve. In 1968, he had actually performed a heterotopic pig-to-human heart xenotransplant. Dr. Denton Cooley, again, someone who needs no introduction in this room. As a resident, he had assisted in the first BT shunt procedure. He founded the Texas Heart Institute, had a long-standing relationship with Dr. DeBakey, and it was the first to implant the first artificial heart in 1969. In 1968, he had performed a heterotopic sheep-to-human cardiac xenotransplant in a heterotopic fashion. Again, this was meant to be more of a ventricular assist procedure than it was to be an orthotopic procedure. So for those, again, who are noticing, we still have not determined what species is best, and none of these have worked so far. Dr. Barnard, very famous again, needs no introduction in this room. In 1967, he performed the first human-to-human cardiac allotransplant. In 1977, he actually performed his own heterotopic cardiac xenograft for patients with refractory cardiopulmonary shock who were unable to be weaned from their bypass. So this was essentially a rescue operation for patients who are unable to be weaned from bypass. Second, I'll say critical case is Dr. Bailey. He was born in 1942. This is, as Emory mentioned, the Baby Faye case. He was born in Maryland. He completed his medical school at Loma Linda, and he finished his residency there as well. He did his fellowship in pediatric cardiothoracic surgery at Toronto Hospital for Sick Children or Sick Kids, finishing in 1975. And what he noticed was that during his time there were a lot of patients with hypoplastic left heart syndrome that were dying because they necessarily had no salvage therapy. So his thought was that even in these very small patients, there should be some availability of performing a heart transplant, even for the very small patients. So he returned to Loma Linda on faculty and began a research program in cardiac for small, young mammals. His first opportunity to attempt this in humans was named Baby Faye, Stephanie Faye Beauclair, aka Baby Faye, as was known to the media. She was born with hypoplastic left heart syndrome, and at 12 days old, with a heart that was progressively failing, Dr. Bailey attempted to do a xenograft as a bridge to allotransplant. He never intended this to be a destination therapy for her, but just long enough until a donor would become available. Interestingly, at this time, pediatric heart transplants were exceedingly rare to come by because no one could decide on who an appropriate donor would be in the setting of these very young patients who had very abnormal neurologic signs. So even patients who had what would be now known as a fulminant neurologic failure were not at the time thought to be suitable candidates for transplantation. On October 26, 1984, at 12 days old from Baby Faye, he performed a baboon to human cardiac xenotransplant. This was not to say destined to fail, but just based on the both the interspecies as well as blood type abnormalities, there was really no chance of this going well. So that donor baboon was blood type AB, the patient was blood type O, which would have antibodies against A and B, and then cyclosporin immunosuppression was the only thing that was available at the time. The patient died 20 days later due to graft rejection at 32 days old. Interestingly, as opposed to Dr. Hardy, this case gained national attention for a number of reasons, and this is probably why people think that Baby Faye is really a household name now. In time, it made its way to Time magazine, where two very big names, both in transplant and in cardiothoracic surgery, John Najarian, who of course was the chairman at University of Minnesota, and John Collins, who is the chair of cardiac surgery at the Brigham, both weighed in on different sides of the same coin, saying that while this was destined to fail, we have to be able to try new things in order to advance the science. This again gained national attention, first of all, because there was a lot of discussion about the ethics of this procedure. First of all, whether or not parents were an acceptable surrogate as a decision maker for children. Second of all, from animal rights activists realizing that there's an increasing amount of animal research that's being performed, not necessarily in the most ethical standpoint. 13 months after the operation, JAMA published a series of 3 papers in an issue that was dedicated specifically to the case of Baby Faye. The first was one that was penned by Dr. Bailey, and this was essentially a scientific paper describing his case of cardiac xenotransplantation. The second one was entirely devoted to the ethics of xenotransplant, in which they described, quote, "There's been highly public concern about the ethical problems involved in this highly experimental surgery, as well as the ethics involved in parents deciding treatments for their children." The last was an editorial more along the scientific side that concluded that transplant from a both interspecies and blood type was doomed, and that hopes for a successful transplant were just wishful thinking, that this was never going to actually work. Interestingly, the month before this JAMA article was released, Bailey had performed the first human-to-human cardiac allotransplant in an infant in the world in 1985, the month before this article came out that was essentially trashing his experimental procedure. That brings us to most recently, the first, I'll say, xenotransplant in the modern world. This was recently published in the New England Journal of Medicine, as well as widely circulated throughout the lay press. This is the University of Maryland case. So Bartley Griffiths was a surgeon. Mohammed Muhyiddin is a well-known, I believe he's an Egyptian cardiac surgeon, but has primarily been on the research side, a very well-funded NIH lab, specifically focusing on xenotransplantation and co-stimulation blockade. Their patient was a 57-year-old gentleman who had hypertension, non-ischemic cardiomyopathy, and a previous mitral valve replacement, who was hospitalized for decompensated heart failure in January of 2022. He had an ejection fraction of about 10%. He had multiple ionotropes. He had a balloon pump that was placed and multiple cardiac arrests. He had to be placed on VA ECMO. They really didn't have any plans with what to do with him afterwards. He wasn't a candidate for an LVAD, and he wasn't a candidate for a heart transplant due to multiple issues associated with previous non-compliance. It later came out that he actually had a criminal record that was used to assess whether or not his candidacy for a destination ventricular support therapy was going to be used. So they discussed this among both the hospital's ethics board as well as the FDA. They petitioned the FDA for the combined use of a Revivicor 10-gene edited pig donor, and then the first use of inhuman an anti-CD40 monoclonal antibody. They used a rituximab and thymo induction, Berinert for C1 esterase depletion as well as steroids, which is fairly standard clinical regimen aside from the Berinert. So just to highlight this pig, because a lot of discussion has been made about this pig. So this is pigs made using CRISPR-Cas technology. They have both a number of genes that are knocked out as well as strategic genes that are knocked in. So those who remember Stephen's grand rounds from 2 years ago, he discussed a lot about the gene editing therapies that have been used to create these pigs. They sought to knock out a number of the different channels for rejection. First, hyperacute rejection associated with the vasculitis, xenograft rejection associated with complement deposition, coagulation dysregulation associated with endothelial injury, as well as, I'll say, standard T and B cell immunosuppression that we think about from the other organs. Here's a time course of the patient. Unfortunately, he died after 60 days. But as you can see, he actually had a fairly rocky course. He was on ECMO for the first 4 days after his transplant. On day 10, he got an XLAP. He had a number of issues associated with pneumonias as well as pancytopenia. He actually had to get another XLAP at day 49 after they reinitiated his ECMO. And finally, life support was withdrawn on day 60 after a long and protracted course postoperatively. This is from, again, a table from their paper. They just kind of summed up what some of the interesting barriers were as a first in human, I'll say, experiment, as well as some of the issues that we have to solve going forward before the next attempt at a clinical human xenotransplant. Some of the things that I think are very interesting from a xenotransplant and science perspective, in terms of deciding who and what should be the next attempt at a clinical xenotransplantation in human. What's the optimal organ? Should we choose somebody who has no other options? So this would be a liver or a heart patient who has no other destination therapy. Or should we choose someone who has a kidney transplant who can always fall back onto dialysis if their kidney were to fail? Who's the optimal patient? For the same reason, should you choose someone who has no other options? Or should you choose a young, healthy person who has the potential to get multiple other either allotransplants or a number of other organ replacement therapies throughout their lifetime, and would be more robust in terms of being able to withstand the rocky course associated with xenotransplant? What's the optimal donor? A number of different pigs have been proposed. Well, they use the 10-gene edited organ pig for this case, but there are certainly a number of other pigs that are out there. And then what's the optimal immunosuppression regimen? This was actually the first attempt using that CD40 antibody. So not only were they using a completely new donor, but they were also using a completely new immunosuppression regimen that had never been tested in humans before. So probably not the time to be trying multiple different factors. And then what I think is possibly more interesting, with the advances in biomechanical, so LVADs getting more smaller and more efficient, as well as tissue engineering, the ability to essentially engineer a patient's own tissues into a replacement organ. Is the future of xenotransplantation still relevant? And in the next 10 years, are we going to be talking about off-the-shelf heart grafts? And the last one is xenotransplant. You know, a lot of the experiments that we talked about were essentially done as one-off therapies, as opposed to the setting of a clinical trial that has very standardized data reporting, as well as a number of other oversight committees. So I think those are two several lingering questions that I have for the future of xenotransplant in general, as well as cardiac xenotransplant. I want to finish with these three quotes because I think they're all very poignant. Dr. Medawar, who of course known as the father of transplant immunology, won the Nobel Prize for his discovery of T-cell stimulation. We just solved the problem of organ transplantation with xenografts one day if we try hard enough in less than 15 years. That was said in 1969. In 1995, Dr. Roy Calm, who's a pioneer of organ transplant in the UK, said that xenotransplantation is just around the corner, but it may be a very long corner. And Norman Shumway, who of course very well known in this room as well as at Stanford, xenotransplantation is a future transplant and always will be. I want to thank Dr. Symbas for coming. I want to thank Dr. Russell for hosting us, and I want to thank all of you for coming. Thank you. No? Very good.
Fantastic.
Very well done.
Thank you, sir.
Thank you.
Thank you.
I'd be remiss if I didn't mention that Brendan is going to be a recipient next month at the American College of Surgeons of San Diego as the best resident educator, essentially, in the country, an award that hasn't been given to an Emory resident for over 15 years. So, engine of the TFD History Society. He's just going to have to guest host when he goes off to do his transplant fellowship next year. But we encourage everyone to continue to attend these as we have them. The real goal is to try to keep people connected with one another. So thanks so much to everyone for coming tonight.
Thank you.
Thank you.
I think Marty had dessert in the corner too, by the way. So
Thanks, everyone.
Tom Dodson.
Yeah. Who's
It's
calling?
Michael. It's Michael. Thank you for your invitation. It was most enjoyable to listen to all of the presentations. Thank you.
Thanks for joining us. Tell Don I said hello.
Shall do.
Good to see everybody. Wonderful meeting. Hope everybody's doing well.
Amy, you're a married woman now.
Thank you.
I am.
Good to see you.
Good to see you too, sir. Take care.
Take care.
All right.
Great.